Yes.
So with your permission, may I start?
Yeah.
Good morning to everyone present here. My topic is the utilization of high and intermediate KDPI kidneys to expand our donor pool, our experience. So why we are going into this topic basically is to understand we need to know the magnitude of the problem. So in 2022, about 11,500 renal transplants took place, with only a deceased donor contributing for about 1,589. The CKD prevalence within India is about 17%. The incidence of ESRD about 229 per million population, and the prevalence of ESRD requiring transplant, needing transplant is at least 2 lakh per year. So there's a wide gap which keeps on widening per year. More than 90% will die on dialysis, and the disease donor rates within India, organ donation rates are about 0.86 per million population. Our state, Tamil Nadu, has about 2.38 per million population. So to start, in the US, in North America and Europe, about 40 to 45% of diseased donor kidney transplants are from marginal donors. While the discard rates are quite high, about a third as per the SRTR data, there are higher DGF rates, that's delayed graft function rates, with marginal kidneys. A relative risk of graft loss and a short-term graft survival of marginal versus SCD kidneys have been found to be comparable. Although the long-term death-censored survival of marginal kidneys is inferior to the standard criteria kidneys, which is about 80 versus 88%. Comparing it with dialysis, ECD kidneys shown that there is a superiority across all age groups. But there is still a hesitancy within India, and most of these ECD kidneys are declined due to a concern of increased delayed graft function, possibility of graft loss, the possibility of increased associated incurring costs, and multiple other factors. So what exactly did we take into our study? The KDPI and EPTS are the first two criteria. So the kidney donor profile index, which assesses about 10 parameters in the donor. So this is assessing the quality of the kidney of the deceased donor, taking parameters of height, weight, ethnicity, race, hypertension, diabetes, serum creatinine. In India, we mostly use DBD kidneys, DBD organs, and presence or absence of HCV in these patients. EPTS takes into account the estimated post-transplant survival, which is parameters of the recipient. So these are 4 clinical parameters of age, the dialysis vintage time, prior solid organ transplant, and diabetes. So our ranges of KDPI are less than 35, 35 to 85, and more than 85% as low, intermediate, and high respectively. EPTS ranges less than 20% and more than 20%. So our objectives were to analyze the short-term graft function of kidneys from the extended criteria donors across moderate and high KDPI categories, to compare the delayed graft function and graft loss rates with historical standard criteria kidneys, and compare the survival of these marginal kidneys versus staying on dialysis, and impact of utilization of these said kidneys on the waiting time. So we analyzed the ECD kidney outcomes at our institute between January 2019 to January 2023. 34 ECD donors were present. The KDPI was calculated. Of these 34 donors, 36 kidneys were transplanted, and the KDPI calculation showed us the likelihood of a post-transplant graft survival. We categorized them into the respective low, intermediate, and high-risk groups. Graft function thereafter was followed up at discharge, the 3-month and 12 months post-transplant, by monitoring the serum creatinine. Delayed graft function was when the patient needed dialysis within the first week of transplant. That was our definition for it. Data was compared with the historical SCD kidney outcomes. We additionally analyzed the transplant survival benefits on patients receiving these moderate and high KDPI kidneys versus staying on dialysis, and the impact of utilizing these kidneys on the waiting time. So we defined marginality as such. So our results. The average donor age was about 47.67 years, the minimum being about 18 years and maximum 68. Donor serum creatinine on an average was 2.18, the maximum being 6, which we had used. The average intermediate and high-risk KDPI scores were 57.13 and 91.6 respectively. 24 kidneys which were used were put on machine perfusion. So across the KDPI groups, we found that the low and high groups had 10 kidneys respectively, and 16 were in the intermediate category. The low, intermediate, and high average scores were 18.33, 57.13, and 91.6. A total of 8 patients had DGF, of which 4 were from the intermediate group, 3 were from the high group, and 1 was from the low KDPI group. The one with the low KDPI group having DGF was due to a long cold ischemia time. Additionally, the serum creatinine, which was analyzed, showed at discharge 3 and 12-month period. The ones with DGF at the end of the 12-month period showed a 1.33 creatinine, and without DGF had 1.09. We used 13 kidneys on the HOPE machine and 11 on the HMP. The average cold ischemia time of the graft was about 10.9 hours, the maximum being 20 hours, which we had used. Average EPTS for about 42.03, less than 2014 and more than 20 were 22, DGF in 8, and no graft loss was seen. So with our results, additionally, we took the transplant survival benefit formula, which is calculated with both the donor KDPI and the candidate EPTS. So a predicted transplant survival across all the KDPI and EPTS groups, we found it to be about 18.23%. And a predicted transplant survival only within the intermediate and high KDPI group, and we did a subgroup analysis, was about 19.3. The EPTS less than 20% had about 12.2%, whereas those with more than 20% had about 21.8%. So additionally, the waiting time reduction, which was there for each blood group, we saw that it reduced by about 3.5 to 5 years. Now, as per our discussion, a moderate and high KDPI graft loss has been seen comparable to the SCD kidneys. We have shown no graft loss. Increased DGF rates are present initially, but at 3 and 12 months, the graft survival is comparable. SCD kidneys are preferred over the ECD kidneys, as most studies will show an improved graft survival and decreased delayed graft function. Discard graft rates are going to be the highest with the high KDPI groups due to suboptimal graft function concerns. In our study, we had intermediate and high KDPI kidneys which did not show graft loss rates which were increased, and comparable short-term survival rates. Utilizing moderate and high KDPI kidneys is definitely superior to staying on dialysis. Machine perfusion additionally will reduce the DGF rates, discard rates, and increase the utilization of these moderate and high KDPI kidneys based on the perfusion characteristics of the machine. And based on our transplant survival model, we showed that we have gained about 21.8% survival benefit by utilizing the intermediate and high KDPI kidneys, especially in the group where the EPTS is more than 20%. Additionally, the number of waiting years also we've seen that can reduce from about 3.5 to 5% in each, across the blood groups. So to conclude, the ECD kidneys with intermediate and high KDPI can be safely used despite an increased DGF rate. Short-term graft survival at 3 and 12 months is comparable with the SCD kidneys with no increased graft loss at 1 year. In India, where we have a dearth of donors, our data shows that appropriate KDPI selection, KDPI usage and selection of these ECD kidneys, along with machine perfusion usage, can lead to an increased utilization of these marginal kidneys without affecting outcomes as well as reducing the waiting time. So we have to stand outside the box to see how the box can be redesigned. Thank you.